Presentation, the Pregnancy Empowerment Project, Skill Building and Tools to Promote Reproductive Health in Partnership with Harm Reduction and Recovery Communities. We're excited to have Drs. Feld and Fallin-Bennett presenting today. After the session, we'll have a quick just CEU submission overview. And with that, we will go ahead and get started with today's session. So I will pass it over to Dr. Feld.
Hi there. Thank you for having us. I am going to share. We have practiced this. Okay. Are we seeing a good screen?
Yes, we are.
Okay. Thank you so much. So my name's Dr. Hartley Feld, and I am with the College of Nursing at the University of Kentucky. Dr. Fallin-Bennett and I have been working on this project to promote reproductive autonomy and empower communities to build recovery capacity and recovery capital, to also include some skill building related to reproductive health. And Dr. Fallin-Bennett has a very long bio. She can introduce herself if you don't mind.
Hi, I'm Amanda Fallin-Bennett. Thank you for having us here. And I'll just say that I'm an associate professor at the UK College of Nursing and a co-founder of Voices of Hope, the Lexington Local Recovery Community Center.
Perfect. Thank you for having us. I am going to be starting, and then we're going to trade out with Dr. Fallin-Bennett in a few slides. So first, we'd like to thank some of our funders, but also to let you know that the material today is our responsibility and not theirs. And then to also acknowledge and thank Voices of Hope. And we also acknowledge that Dr. Fallin-Bennett was a co-founder of Voices of Hope, and they do serve 23 counties in Kentucky, and they were our majority partner for this work. And so we couldn't have done any of this without Voices of Hope. We have submitted our learning outcomes already. So these are the things we're going to be talking about. We hope you have some interesting takeaways that you can apply to your practices. Our work really started with the public health goals, which is related to unintended pregnancy. And so we were really focused on kind of why and how populations of people with substance use disorders or people who use drugs have the highest rates of unintended pregnancies. So we do know that this is a health disparity, that they have over 75% of their pregnancies are unintended. And that means that they're mistimed, unwanted, or unplanned. And so those might not be great words to describe pregnancy for people who use drugs. So but we are going, again, we started with the public health idea of what is happening here. And then eventually we are kind of changing our language and approach based on some of our findings. And so one of the reasons that we're so interested in addressing and discussing unintended pregnancy is because it's associated with depression, stress, and anxiety. All of those things obviously can erode recovery and recovery capital. And then also, eroding recovery and recovery capital contributes to our high overdose and maternal mortality. Kentucky is one of the leading causes of maternal mortality is overdose in the state of Kentucky. And so that we think that if we can address or discuss or highlight some of the unintendedness of pregnancies, that this could contribute to also reducing maternal mortality. One of the issues with people who use drugs or people with substance use disorder is that they have high rates of late or no prenatal care. And so they're not in spaces where they can benefit from a lot of interventions. And so that is one of the goals, is that we're trying to increase access to reproductive and perinatal care. And then sadly, having an unintended pregnancy, and this is not specific for people who with a substance use disorder, but it is one of the earliest predictors of child abuse and neglect. So it's a huge issue for our state for that reason and for the country. And just to start out with a little bit of policy work, because it's really timely as to why this issue is in the forefront at this time. And on some levels, we want to understand that before Dobbs, we knew that a lot of people who had opioid use disorder or opioid dependent had more pregnancies than people who didn't use opioids. So 54%, if you can see in my little green green box there, of women reported having 4 or more pregnancies in their lifetime compared to 14% in a nationally representative sample. And then they were 5 times more likely to have an abortion than a national sample. And so we know that changing the abortion laws in all of the states here that are highlighted in red with the most restrictive also impacts people who use opioids or people with a substance use disorder. And so the American Journal of Public Health just recently had a nice piece about what some of the state policies are that are happening in restrictive states that might support or not support people in terms of accessing healthcare, and particularly highlighting things that can help disadvantaged pregnant people and their families. And so we know that, let me move my slide, sorry. We know that the highest percentage of uninsured women of reproductive age, that the restricted states have the highest percentage. We know that the restricted states in red are less likely to allow pharmacists to provide prescribed contraception, and that a higher population of reproductive age people live in a maternity desert in these red states. And that accounts to 1.1 million people who don't have access to a hospital or a birth center. And this is also pretty close to the numbers who don't have access to a full range of reproductive health, like birth control options. And then the most restricted states also have lower WIC enrollment and childcare assistance. They have lower opportunities for TANF. And then no states with the most restrictions had any kind of mandatory paid leave or paid medical leave. It was highlighted that Medicaid expansion has been associated with a significant use and uptake of contraception, especially long-acting reproductive contraception, which decreases the rate of unintended pregnancy and has the greatest gains in adolescents. And I just want to highlight it and kind of give a shout out. Kentucky does a lot better than a lot of these other severely restricted states. We were highlighted, in this article, they demonstrated that we still have Medicaid expansion. Our rates of WIC enrollment were not as low as some of the other states. But the reason I wanted to highlight a lot of these other policies is because we want to hold on to these if we want to really support women to improve their access to care, that these are things that are associated with being able to access care and promote the well-being of women. And we know that our folks with substance use disorder are going to be most impacted by any of these policy changes. And so I just wanted to highlight that and give you a resource that was really interesting in terms of statewide policies.
Dr. Feld, somebody put in the chat, they're asking if you could explain what Dobbs was. I thought you might want to do that before you move on.
Yeah. Thank you. I'm so glad that you're reading the chat. Okay, so I can't see the chat from this view, so thank you so much. So Dobbs was the Roe versus Wade, the overturning of Roe versus Wade with abortion policy. And so the Dobbs decision, when it was overturned, abortion was no longer it became a states' rights issue instead of a national issue. And so Kentucky has the most restrictive abortion policies, and so do all of the states that are in red. And so we want to support women in the states that have these restrictions, knowing that we have additional barriers to that perhaps they were getting more abortions in the past and aren't getting them now, or don't have as much access to them. So there are policies that we can help to bring out kind of the best in terms of their access to other forms of healthcare. And to support them from getting pregnant if they don't want to be pregnant. Any other questions there?
That's the only one I saw.
Okay, thank you. Appreciate it. And one of the reasons we're really interested in this work, especially with a harm reduction lens, is that there's a lot of things that happen when people have sex or in relationships or doing perhaps transactional sex or sex work that can be coercive, and in terms of birth control use, in terms of whether or not they're able to fully access healthcare And we've heard, some stories from women in our work whose partners wouldn't allow them to use birth control. Sometimes there's coercion from healthcare providers or from researchers, and we're going to talk a little bit about some of those injustices. And so we just want to kind of lean into the fact that there are some very coercive practices, and that could be having a heavy hand in terms of whether or not you use birth control, whether or not who gets to decide whether or not you have children or have a pregnancy. And so historically, we have been, sorry, I keep moving my share screen. Historically and currently, there are some things that are happening in research that are really, that make these decisions rather complicated. So what happens, there are some research studies where financial incentives pay women more money to have their tubes tied or to be sterilized than they do to use other methods of birth control. And if you're a population with a substance use disorder, you might be very convinced to take more money to have a permanent sterilization and never get pregnant versus trying something that might be more appropriate for you. And so a lot of these programs are designed to decrease the number of pregnancies and birth by people with substance use disorder, rather than meet them where they are and decide what kind of pregnancy or reproductive life plan they want to have. And so we want to just lean into this. We've had a lot of people discuss with us of like, oh, maybe you should pay people to get their tubes tied. And we've had healthcare providers say that to us and other providers. And there's just a lot of injustice that occurs for that, because we're really starting with the point that we don't want people like them to become pregnant. And that's not a starting point. That is discriminatory. So this helps perpetuate stigma. And so stigma is when we label or stereotype a person as with an undesirable characteristic, such as having a substance use disorder. And then discrimination is unjust actions that people take in response to their beliefs. So in that example of some of the things that are happening with this program called Project Prevention, is that when a person with a substance use disorder is believed to be incapable of parenting, which is a stereotype, that they're monetarily incentivized to accept contraception. And so and the reason we want to bring this up is that people in the recovery community have told us that they feel, and this is also in the medical literature, that they feel like people want them to use contraception, for one thing, and also to use the most effective forms of contraception. And that there might be a bit of a heavy hand for them to do that, rather than have all kinds of choices, just like any other women would have, in terms of what they want their families to look like. And then we also want to call out that there's this intersectionality of social constructs. We talked about maternal mortality, and the literature, we know that 3 times more Black women are dying in childbirth and surrounding pregnancy than white women. And so race is one of these intersectional social constructs. We also know that people with low socioeconomic status are more impacted by a lot of this work. And if you don't have access to healthcare, we've discussed coercion a little bit. We know that there are also some gendered disparities, and that women are expected in their recovery pathways to take care of families and children, and oftentimes don't take care of themselves. And there's just a lot of stereotypes about that as well. And that they have less access, or are less likely to engage in MOUD and treatment. And all of these are sort of compounding on top of one another as to why this is such a complex issue in our communities. Some of the barriers to receiving reproductive and perinatal health care, we talked about fear and stigma. Specifically, people told us that one of their biggest fears is Child Protective Services, and that they will have very little control over a pregnancy if they were to get pregnant. And then a lot of women particularly don't use birth control because they have they have a low perceived risk. So they either have an irregular period or no period, and this can be common with people with opioid use disorder in particular, or that they don't have sex very often, which is something that also sounded common enough as to a reason to not access healthcare. They have a lot of competing priorities, and a lot of those have to do with living below the poverty line. And then they are increasingly exposed to exploitation and violence, especially being a person with a substance use disorder. They're 3 to 5 times more likely to have to be victimized by intimate partner violence. And then the legal and child custody concerns do certainly fall to women. And so these are also gendered issues. And then they have less access to treatment. All right, I'm going to pass it off to Dr. Fallin-Bennett to highlight some of our partners and the work that we have done that has informed our work.
Thank you. And so in the spirit of harm reduction, in terms of wanting to empower people who use drugs and people with lived experience to be able to co-create this intervention with us, we started, from the very beginning with partnering with recovery community centers. And so some of our earliest partners, one was Voices of Hope, which we've mentioned. The other was the Louisville Recovery Community Connection, back when it was with 7 counties. And so I think Dr. Feld had a lot of humility when she approached this project, because instead of coming in with her idea that she was definitely set on, she wanted to hear feedback first. And so the original idea in part was DEPO was to be able to provide that type of contraception in partnership with RCCs. But when we started doing focus groups with our early partners, we learned that maybe that wasn't really what the community was interested in. As just one example, there were barriers and there would be a need for a clinical partner and things like that. And so we heard pretty loud and clear that part of the intervention should be emergency contraception. And so that was taken into account. And so she'll say more about the intervention later. I just wanted to give some examples of, so in the very beginning, we spoke with staff at recovery community centers and also people accessing services there to ask what they would want. And then as the project has expanded, we've also partnered with the Kentucky Harm Reduction Coalition and with the RCC VOA Clay. And I see at least some people have joined from VOA. So welcome to them and any of our partners who are here.
Thank you. Thank you. Wait, just to give a little shout out in case people don't know that Depo-Provera is an injectable contraception that works for 3 months. And initially, we wanted to start with a global model that used that was very effective in low and middle income countries that used Depo-Provera. And so we asked a lot of people about that in the beginning, and it wasn't as desirable for various reasons, and in part because it was an anonymous and they would have to seek healthcare in a time when perhaps they weren't ready.
And so we also, because the original project was incorporating within recovery community centers, we were working within SAMHSA's definition of recovery, which is very broad and person-centered and strengths-based. And so many of you on here are probably familiar with SAMHSA's definition, but one part of it that we really leaned into was the importance of peer support. And so people with lived experience in recovery from substance use disorder would be the people who would be like really leading the development of the interventions, leading the trainings, and then leading implementation. And so this fits in with the body of research available on peer support, which shows that working with peers, sometimes referred to as recovery coaches, peer workers, peer mentors, can help build trust. And there is an association between working with peer workers and accessing healthcare. A lot of times this is in the context of linking people to substance use disorder treatment, but we thought it would fit in here with linking people to reproductive health services. Working with peers increases your social support, and has also been demonstrated that it reduces problematic substance use, as well as associated harms like incarceration, repeat emergency department visits, things like that. And so peer workers, again, recovery coaches, mentors, the main focus of what we call recovery support services is to build recovery capital. So in line with SAMHSA's strength-based definition of recovery, this is largely strengths-based as well. And so we try to think about when you're working with someone, what could you do to build their resources, internal and external, to be able to sustain their recovery. And so this does refer to things like personal capital, which is your education, your job skills, your job, social capital, so people in your life that are supportive of your recovery, so positive relationships with friends, family, also the recovery community. And then part of it, though, does also refer to your physical and mental health. And so reproductive health, of course, has, lots of impacts on your physical and mental health. So it fits within the existing framework of recovery support services to build recovery capital. And so these images come from Ohio State, and we just really liked the way that they visually laid out this information about peer recovery coaches. So I'm sure some of you listening to this are very, very familiar with recovery coaches and the work they do, but we want to make sure everybody's on the same page. And so we would start with, so how would a peer support, a mentor, work with someone? And it's all centered around a client's or a participant's goals. So their own recovery goals, what they would like to achieve for themselves. So they don't start with us having a goal, but rather figuring out what the participants' goals are. And so providing social support, making a recovery plan, things like that. One question that you do get asked a lot is, how is this different from a sponsor? So if anyone is familiar with a 12-step pathway of recovery, many people have a sponsor, and peer workers are different from sponsors in a variety of ways. For one, they are paid. It's a type of employment. A sponsor is a volunteer position, but also a sponsor has the role of helping someone work the 12 steps. And so that would be different from a peer worker who would be working with the participant to achieve whatever goal they might be interested in that day to build their recovery capital. So someone certainly might have a sponsor and a peer coach. They're not in conflict with each other, but they do have different roles. And so sometimes peer workers provide services, to anyone in the community. Like, for example, anyone who walks in the door of an RCC, but other times someone can be specialized. So they might be a recovery coach that works specifically with women or specifically with people who are incarcerated. And so there are peer workers who work specifically with the child welfare system. And I see that there are some questions in the chat. So I don't know, Hartley or Dr. Feld, if you'd like to ask me the
I can't
questions.
see them because I'm sharing my screen and not yours.
Okay, so we're going to take just 1 second to read this. So I respect and appreciate you're giving those who are struggling a seat at the table. We try so hard to figure out certain populations and fail to include them in conversations. If we really want to know what's going on, we have a duty to ask those who are affected. So thank you for that. And then we have a lot of people echoing that sentiment. So we hope that we did an adequate job of this in this project, but we're also open to your feedback and can always learn more about better ways to do that.
And Dr. Fallin-Bennett, could we do this a little bit like a podcast? If you could you explain a little bit as to why we chose to work with recovery community centers who hire the peer recovery coaches so you said they're hired by RCCs. What's the benefit of working with an RCC versus working with one inside of a hospital?
So for one, I have a bias, as we've disclosed, because I am a co-founder of an RCC. But one benefit that I would say is that when you work in a specific setting like a hospital, oftentimes there's an end to when you can work with a participant. So if I work with you, like for example, if I was a peer support specialist in a NICU, oftentimes when your baby is discharged and you leave, I'm no longer able to work with you anymore. And you certainly couldn't come back and visit me physically within the hospital. And so when someone is within an RCC, there's no end time to services. And so regardless of what happens in someone's life, whether they enter, exit treatment, enter, exit incarceration, things like that, you can come back to your peer at the RCC. And also RCC services are free of charge. And so there are no barriers to access.
Are we ready for the next slide, or are you going to do the number 3 here?
I did.
Okay, thank you.
And so these are just reiterating a few of the benefits that we mentioned earlier, but individuals who work with peer mentors, recovery coaches, etc., are more likely to access treatment, less likely to have problematic substance use, and also are more likely to receive substance use services faster. So there are these benefits, known benefits of working with recovery coaches. Again, it does go beyond just accessing substance use treatment services, that's important, but also mental health services. And we used within our project, we use, as I mentioned, SAMHSA's definition of recovery, which does not use the term sobriety, so that we could be a little bit more inclusive. But there is research that shows that working with a peer recovery coach also increases likelihood of achieving sobriety. And so I mentioned that preventing an unwanted pregnancy or a mistimed, unintended pregnancy could have an impact on recovery capital. It does fit in within promoting someone's physical health, financial stability, etc. And so, as I mentioned briefly, we did do some focus groups early on with people who were receiving services at recovery community centers. And they shared with us that, having these experiences led to more instability, housing issues. So as an example, you might be living in a specific recovery house, and then if you become pregnant, you're not able to stay. It would be one example. Having a pregnancy at a difficult time in your life could increase stress, anxiety, relationship burdens. And some people shared too that this had happened to them and it disrupted their existing social networks. So here are just some quotes. He split when he found out I was pregnant, or when my baby was taken away. It put me right back into using. It put me into a bad spiral. So we heard a lot of stories that just sort of reiterating how an unwanted pregnancy could harm recovery capital. And so we have in the chat that someone says that they are a family mentor in the child welfare system, and their role is so vital to these families and children. And so, yes, that is so great to hear that you are a peer worker working within the child welfare system. That's really great. And so we had mentioned that we partner with recovery community centers for a variety of reasons, one of which it just increases access throughout the lifespan. But another reason is that a lot of recovery community centers have a broad definition. So similar to SAMHSA, who the definition is less focused on abstinence and more focused on overall well-being, reducing problematic substance use. And so by partnering with RCCs also, we felt it's inclusive and a way to also partner with people who use drugs. And so we, of course, don't have time to have a whole talk about what harm reduction is, and many of you are probably familiar, but we just wanted to differentiate for you that harm reduction in terms of lowercase harm reduction refers to things like services. So if we were going to talk about a syringe service program, reduces infectious disease, a syringe service program is a service that's aimed at reducing negative consequences associated with drug use. But harm reduction uppercase is a philosophy. And so it's a movement for social justice that's built on a belief in and respect for the rights of people who use drugs. So a syringe service program could operate also with a big, uppercase harm reduction philosophy, but it might not necessarily. So just so we can differentiate, there are services, and then there's a philosophy. And so in a little bit, we will tell you more about the services that we provided within this program. And then one of the tenets of harm reduction that's really applicable here is that harm reductionists would recognize the realities of poverty, class, racism, social isolation, trauma, discrimination, and how much that could affect someone's vulnerability to and capacity for dealing with drug-related harm. And so another thing that was important to talk about in this project is how much stigma there can be. So there's generally in our society, there's some stigma around using substances. But when it comes to a person who's using substances when they're pregnant, there can be so much stigma and shame. And so this comes from the Academy of Perinatal Harm Reduction. We used several things from their toolkit that you'll see in a bit. But what was important is to think about if we hyper focus on someone's substance use during pregnancy and they feel a sense of stigma, that stigma can be internalized into shame, so feelings of disgrace, humiliation. And so this is all compounded during pregnancy. And so that's one reason that it's so helpful also to partner with peers, is because we want to reduce the feelings of shame that someone might have for going to healthcare. And so this is a quote from the director of the Academy of Perinatal Harm Reduction. She says, "It's easier to get better if you believe that you're worth changing your relationship with substances. When people internalize stigma, it leads to anxiety, isolation, and loss of self-love." And so, again, when we talk about recovery and center it, merging it with a harm reduction philosophy, recovery is any positive change. And so this is another way that you can increase the reach of your services to people who are not in abstinence-based recovery, that peer workers can work with people to take any positive step, regardless of the one that they might be ready for. And so there are other examples. So using less often, not using alone, using substances with a different route of administration. So stopping injecting, for example. But also, harm reduction and recovery support services can mean helping someone with safe housing. It can mean linking them to mental health resources or education. And in our case, it could mean helping link someone to prenatal care visits.
Or reproductive health.
And so just so you all are familiar, this is the toolkit that I was just referring to. And another tenet of harm reduction is that it just calls for the non-judgmental, non-coercive provision of services to people who use drugs.
Fabulous. Is there anything in the chat we should address before we switch back?
So there is a message. It'll take me 1 minute to read it out. So someone says they worked with several participants who express an interest in going to treatment, but they have a pet. Am I aware of any resources that would potentially board animals? I think that is a really great question. And while Dr. Feld is talking, I'll try to put a link in the chat, because I think I know of one resource in the state, but other people may know of one. And so please also put that in the chat.
That is great, a great question. And I think we're finding a lot of people who are leaving other crisis situations, whether that's a hurricane or a wildfire. If there's no place for your pet, then they're less likely to leave. And so I think there's a lot of interest and funding around that, especially for women experiencing violence. So there might be some ideas there. Thank you, Dr. Fallin-Bennett. I wanted to just reiterate, kind of bringing a lot of these things to our purpose and mission. So we decided with our recovery community partners that our purpose and mission really shouldn't be about reducing unintended pregnancies. It should be about, it should be much broader, based on our like more holistic, humanistic, inclusive of harm reduction approach. And so that we're focusing more on something called reproductive autonomy, which is having the power to control when and whether to become pregnant, and then the well-being of the person who becomes pregnant, or the woman, because a lot of times they feel like they're kind of dropped or left behind if they're no longer, after they become pregnant. And we just want to really reinforce that, like, having a supportive environment for the woman, so that she doesn't feel like she's just a vessel of the pregnancy. So we also, as a mission statement, our community helped us develop this, that we believe people who use drugs have the right to plan or prevent a pregnancy and deserve access to the tools to empower them to live self-directed lives and create positive change. And this self-directed lives and positive change really comes out of the recovery language of the recovery community center. So we were excited to kind of change the way that we were thinking about this from a public health approach, to be inclusive of where people are, and also to acknowledge the past harms that we've done.
Dr. Feld, I'm
Yeah.
sorry. There's an ask. Could you give some examples of these types of services other than termination of pregnancy?
Oh, of reproductive health.
I would believe so.
Okay, so I think so we refer to perinatal health as as anything that could be preconception, meaning you want to become pregnant and you want to work on being as healthy as you can before you become pregnant, and then during a pregnancy, and then postpartum health, and all of those are under an umbrella called perinatal health. And so we kind of go back and forth in our language about this because reproductive health has a whole lot of other things that fall under it, like whether you contract HIV or a sexually transmitted infection falls under your reproductive health. We are talking mostly about reproductive health of when, if somebody would like to become pregnant or not like to become pregnant, what are some things that they can do to prevent that or help them to plan a pregnancy? And so we talk about reproductive health as being primarily for our work, we're talking about how it involves pregnancy and how you can have control, autonomy, respect, and systems of support that can really like bring all of these to the fore. So we're talking about this kind of like well-being that people deserve in order to have the family and control and the things that they want in their lives. And so there's this, I'm just going to segue into this slide because it does kind of lean into how we're talking about it. So we're talking about things like access to birth control. We're talking about having conversations. And just one more example to kind of give you an example of where this isn't happening in the community. And some of the people that we interviewed told us about a clinic that they went to that would not allow them to, they wouldn't prescribe birth control until they took a drug test, which has nothing to do with each other, right? So we are trying to really shout out that there are a lot of these things in the community that are happening that people are saying, like, I couldn't access what I wanted to, or I missed my appointment and I got a letter saying that I can't come back again. So there are whole lot of barriers that people who maybe perhaps want to access healthcare, but they don't want everybody to know their business about whether or not they're using drugs or have a substance use disorder. And so we, as a mission statement, think that they have the right and deserve to be able to access those services and get birth control when and how they want to receive it. Just like people who don't have a substance use disorder should as well. And so that's like a human rights approach to reproductive health and well-being. And there's this great group called that is called Power to Decide, who came up with a lot of these the tenets of reproductive well-being. And again, it's supporting women or people who can get pregnant across the reproductive age group. So from the time that they're 18 to about 45. And that every gender identity and sexual orientation, race and ethnicity, and every person who uses drugs or has a substance use disorder should have the right and autonomy and control and respect and a system of support in order to uphold their reproductive well-being. So it's not as easy as just, there's a lot of, like in healthcare in particular, and we're both nurses, so we've seen and heard this from people that, you know, there's a lot of finger waving as to like, well, they should have known better, or they should have not engaged in things. There's a lot of judgment that happens on the back end of whether and when people become pregnant, that they should have known ahead of time. And we want to just acknowledge that there's a whole lot of barriers to getting there. And those barriers are just multiplied for people with a substance use disorder. And so these are ways that we can support people as whole people instead of really just focusing on the one thing that they could or shouldn't have done differently.
So, and just one more comment. I'm sorry, Dr. Feld, but it
No, I
seems
like
like
this.
you're getting into this anyway. But
Yeah.
there's another comment it says it seems that we might have been advocating in the beginning for the termination of pregnancy. And so just in case, we would just want to say that absolutely not would either one of us ever advocate that people who use drugs should not have as many children as they want and have the right and the ability to parent them. And so I just want to say that because it's really cornerstone to the work. And so thanks for saying that you got that impression so that we could have the chance to really clarify that.
Yeah, and thank you. And I think we want to be sure that no matter how you feel about abortion or what's happening in our state and some of the other states, that I think that we are here today to try to promote health and reduce barriers for all women, particularly those who have additional barriers with a substance use disorder. And so I was trying to call out policies that where we can support women, especially in states where they don't have access to abortion, knowing that people in the past, when they could have abortions, were more likely to access them if they had a substance use disorder. And so whether we, agree or want that to happen is not what we're really talking about today. And that's really everybody's personal, decision. But it's one of the things that we want to call out policies that can help support women and meet them where they are. And not there is a lot of coercion. I think on the slide that I talked about where there's family who perhaps can be coercive, and there is family who can weigh in, and people have told us about this where their family wanted them to get an abortion, and we wanted to say that is, not that they absolutely can be a fabulous parent as a person with a substance use disorder, and that is not something that should prevent them from making the best choice for them. So if they want to be a parent. So sometimes there's some family pressure to get abortion if you are a person who has a substance use disorder. And so we train our peer recovery coaches to have those conversations with people to say that you can still be a fabulous parent. And whether they're, even if your partner wants you to get an abortion or your family, because you're a person with a substance use disorder, it doesn't, you get to make that decision for yourself. And that they try to uplift by sharing their own experiences of having children and pregnancies during their own struggles with substance use disorder. So again, that's a conversation that's really better received from a peer with the lived experience, that where there's not shame and judgment in going, in terms of making those decisions, because it is very complex. So I'm glad you brought that up. It is a challenging topic that we're all, kind of making our way through. So to get into this a little further, and we will talk about it a little bit more with the morning after pills, but based on our qualitative work, we developed this model called the Pregnancy Empowerment Project, and we have partnered with several recovery community centers where they are giving out these products as part of their harm reduction mission. And so if you remember, the small harm reduction, the small H and the small R, are about strategies, and this is one of the strategies. And so one of the things that we have done based on hearing from folks of what they would like in terms of wanting to control their own fertility to either plan or prevent a pregnancy, and also know their status, is these are 3 items that were highlighted as over-the-counter things that are easy to access for people who can purchase them. However, we wanted them to be available to people who could not afford to purchase them. And so specifically, we have choose to prevent is the morning after pill. So we're going to highlight a little bit more of how they work, but they can be taken after you have sex to prevent ovulation, delay ovulation, and so that you never get pregnant. And then, you can use the prenatal vitamins if you wanted to plan for a healthy pregnancy. If you're 90, it's recommended to start taking them about 3 months before you would like to become pregnant, but a lot of people don't. And then also to continue taking them in the early pregnancy to prevent birth defects and other issues. And then the pregnancy tests, people wanted to understand and know their status. So we did hear from people who had stolen pregnancy tests because they wanted to know their status and they couldn't afford to buy one. We know that knowing your status makes you kind of make a decision about what kind of future you want, and perhaps changes some behaviors. So to highlight, I go back and forth between calling this emergency contraception and the morning after pill. It is the same thing as Plan B, but we don't use the brand name because it's quite expensive, but there are a lot of generics out there that are cheaper. So again, this prevents pregnancy after you've had sex. It allows women to control their fertility. It reduces the need to seek out an abortion. So if you never ovulate, you don't have the opportunity for the sperm and the egg to meet. And so, and not never ovulate, it just delays ovulation, it delays it long enough so that the sperm kind of dies before the egg ever comes out. So, so it can be kept on hand in case you have an emergency or crisis. So people really liked this because they thought of it almost like a Narcan of like, yeah, we hope we don't have to use it, but if we're sexually assaulted, if a condom fails, if we don't know what happened the night before, we can use it in the morning. And so it's something that people at the recovery community centers and harm reduction organizations are passing out to take with you in case if you're a person that could be at risk for an undesirable pregnancy. So again, it's contraception. It works before a pregnancy, and the kind that we are, the kind that's over the counter works best in the first 3 days. It can work up to 5 days after sex, but for the most part, the 3 days is a better window. There are some that you require a prescription that can last longer for 5 days, but we are only providing the ones that you don't need a prescription for. And again, I've talked about this like several times, but it just prevents or delays the release of an egg, similar to other birth control methods or oral contraception. If you are already pregnant, so you have an egg and a sperm that are already implanted into the uterus, it cannot terminate or interrupt or reverse an established pregnancy. And nor does it harm a developing embryo if you're already pregnant. So this is not an abortion pill. We get a lot of questions about that, and there's a lot of education to be had in our communities about this, because the abortion pill works when you're already pregnant. It is not something you can get in the state of Kentucky, and it is not something we're promoting or that we are passing out in any way. We are trying to give women more opportunities to not ovulate so that they can delay, so that they don't become pregnant if they don't want to be. So any questions in the chat about this one?
Yes. Do you have educational materials that go along with this when you distribute them?
Yeah. Oh, thank you. Yes, we do. So we have an educational insert that goes with each of the 3 products that are in our pregnancy empowerment project. And we do a kind of a low literacy insert. Also, the emergency contraception comes in the original box. And so there's more education on the inside of the package as well, the same that you would buy at Walgreens. So it is, we do education for the peer coaches about it, about how to talk to people about it if they have any questions. And we have this little insert that goes in a baggie with all of the emergency contraception. And it also has my email address. If anybody wanted to reach out, I'm happy to connect them to other resources if they need to. Most people don't, but it has, but I wanted them to have somebody that they could contact. And then also when we worked with some of the peer coaches who were championing this, we had a peer coach's contact information in the baggies as well, so that they could reach out to them if they wanted to be connected to healthcare providers for more, in-depth decision-making on what happens here. So all of them have an educational insert, and I'm happy to share those. My last slide is about things I can kind of share with the group if you want me to send out. I'm happy to share the tools that we've developed so that you could use them in your own practice. And then the prenatal vitamins, we know that these add vitamins and minerals for growth and development for a healthy pregnancy. And we know that a lot of women with substance use disorder may not have a healthy, balanced diet. They may not have access to healthier food. They may not be able to afford them, and they may not prioritize it depending on where they are in their lives. So the prenatal vitamins have the most benefit for people who have the worst diets, basically, or have the most challenges with getting enough of a well-balanced diet. And so these are really particularly important for people who use drugs if they aren't eating or they aren't eating enough, or they aren't eating a well-balanced diet. So so when you use them, again, 3 months before pregnancy is recommended. You can start taking them anytime. And we did, based on our qualitative interviews, people told us that they really don't like the iron in a prenatal vitamin because It causes constipation, and so does using opioids and other drugs can cause constipation. And so we didn't want to, we wanted to reduce all of the barriers to taking it. Also, people told us they liked the gummies because they tasted sweet and they could chew them, and they were easy to chew even if you had poor dentition. And that none of the gummy formulas of prenatal vitamins have iron in them. So it is recommended that you do take iron, and we recommend that you have a conversation with your healthcare provider about that for pregnancy and pregnancy planning. But if you're not going to take it because of the iron, this was kind of a low barrier way to start taking it. And you can get iron from other foods if you have a balanced diet. Okay, so pregnancy tests. We pass these out, and we also provide information about how to read it and what it's measuring. A lot of this information that I have on these slides is what we pass out in the educational inserts. So testing urine for pregnancy, we're testing a hormone called HCG that's formed after the fertilized egg implants into the lining of the uterus. So you won't know if you're actually pregnant for several weeks, as I think a lot of you all probably already know that. But knowing your status, so why we included this in our model, because knowing your status could lead to earlier intervention and move from ambivalence. So a lot of our peer recovery coaches do motivational interviewing where they talk a lot about ambivalence of how, people are kind of ambivalent about a lot of things in their lives, especially in early recovery. And so sometimes just knowing your status moves you from ambivalence. So maybe you're like, okay, I need to do something about this because it's not going away. And so the earlier you decide to go to prenatal care, or if you decide to not have pregnancy and travel outside of the state, the earlier the better for both of those things. So evidence to support having a pregnancy test. People reduce substance use when the pregnancy tests are provided earlier and free. So the literature really only supports this for alcohol use, but we think that this probably happens as well for people with a substance use disorder, that they might start tapering. And some people had told us that they do reduce use once they found out. And also it just moves people kind of into a readiness phase for treatment in a way that maybe they weren't ready before. And then how do they work? They're most accurate the first day you were supposed to get a period, but the problem with that is you have to have regular periods, and you have to have a calendar and mark it and be on top of it in order to know when to test yourself. But it can be, if you just sort of most people will accurately test by the third week. So you can try to do a pregnancy test between 2 and 3 weeks after you've had sex. But at 2 weeks, you may or may not get a false negative, but at 3 weeks, it should be indicative of an actual pregnancy. So it's best to use the first urine of the day. It's the most concentrated urine with the pregnancy hormone. And then we also recommend, of course, we advise that you retest and you go and get a blood test from your provider. Because there are some very small reasons that you would test positive when you're not, or test negative when you are positive. And so, the 2 lines indicates that you're positive, and 1 line just means that you've had enough urine that is a good test. And it means you're negative, but it also means that you have put enough urine on the strip. And so we pass these out with this information. And then just some kind of highlights of why these products, again. They're delivered by or associated with the peers. So we know already, based on some of the presentation that Dr. Fallin-Bennett did, that peers are there, they're supported and they're trusted and they accept them. And so these are good conversations or places to go for advice on very difficult and complex issues. And that we hope that these will be conversation starters about reproductive life planning. And so if you're enrolling in peer support services, you're looking at a lot of life plans, right? And so this could be start of it, of how many children do you want to have? Do you see yourself having a family? Do you not see yourself having a family? And are you doing anything to prevent that? We know that it could reduce the barriers and shame, stigma, cost. And a lot of people in our qualitative work really wanted to have the information before they interacted with the healthcare system. And they wanted a little bit more control than just going into the healthcare system. And that is why, another reason why kind of this lands nicely in the community. One of the people talked about the appeal of emergency contraception, and one of the rationales, one of the reasons that we were excited to talk about this is because people don't have to make a long-term decision. They can take it one day at a time, which is very common in our recovery language. And then just one more highlight is that the pregnancy test, people told us they were afraid to get a pregnancy test when they went to the provider because they didn't have control of their urine. And they did not want to do it in a clinical setting. So they get to decide what they want to do with that information. They take the pregnancy test home or use it in the recovery community center, and they get to decide. I see I'm getting a little close, I'm sorry, but we have distributed a lot of items. Voices of Hope is working, is still distributing these items at their recovery community centers and in 11 counties of where they work. And so their numbers have been the highest. We've been working with them the longest. We have also partnered with Kentucky Moms Matter, who support pregnant and parenting people with substance use disorders. We allowed people to kind of pick and choose what they wanted to do. So some people just wanted prenatal vitamins. Some people did not want emergency contraception. It perhaps felt too controversial in their communities. And so they kind of could pick and choose the pieces that they wanted. Kentucky Moms does not distribute as much as some of our other sites. We have partnered with Volunteers of America. Thank you very much to our Clay County folks. And they've done a great job of incorporating it into their peer recovery services. And we have products at these organizations for another couple months with our funding. So we wanted to also let you know that we are not able to provide funding to provide everybody on this call with the harm reduction items, but that you all could consider them as part of a harm reduction pathway in your own work. So we were able to enroll some participants in a study to understand a little bit about where they are and what they would like to happen. And just sort of the big takeaways for this is that 30% of the people that we spoke with or worked with, not we, the peer recovery coaches worked with and collected this data for me. So for us, so thank you. 30% wouldn't mind becoming pregnant. So we're not having a lot of those conversations, and it is a little bit awkward, but I think it's something that could really be discussed as in peer spaces, because it's a safe place to discuss that. And then of those who would like to avoid pregnancy, 87% were not using any contraception. And some were using condoms. And so we have some work to do here as to why and how to get there. Some of the resources that we were able to provide, or that our recovery community centers were able to provide, included a lot of social needs, included a lot of additional referrals based on this additional training. And they were able to link 25 of their participants who were interested into perinatal or reproductive health care. So they were either pregnant and got them into prenatal care, got them into preconception care if they wanted to become pregnant, or were able to get them connected somewhere with to provide birth control. And that's only 25% of the people who were interested. And so it's not a huge percent yet, but it is nice on a lot of levels to think that it's not being overly linked, if that makes sense. Like, we don't want 80% of the people, because there might be some coercion going on. We want people to still make decisions that are right for them. And so 25% we thought was successful in terms of getting people resources that they may or may not, that they may want. One of the questions that we asked that I can provide these, if you'd like to add them to your organizations, is that we looked at empowerment measures that are predictive of accessing healthcare, because we thought that the peer recovery coaches could then use these in their coaching to make sure that people felt like they could move forward with starting either prenatal care or contraception. And so people who were pregnancy capable had empowerment issues about safety and having supportive people in their lives. And then they also were not confident in their level of knowledge related to sexual and reproductive health. And then people who were pregnant also had issues, and these were low scored items, like feeling safe in their environment. They felt judged or stigmatized when seeking healthcare. And then they also had a low score related to what we defined reproductive autonomy, that they didn't have the power or control to decide when and if they became pregnant. And so that was, sadly, one of the lower scores. And then our lowest scores when we were looking at recovery capital with this population were related to their global physical health, that they didn't have enough energy to complete tasks, and they had pride in their community that they felt a part of. And so the peer recovery coaches use these low scored items to also help guide recovery coaching. So really quickly, and I hope that you have a copy of this, and my email and phone number on the last page if you have to go, but we have resources that you can implement at your organization. Again, we are not able to add more partners with those products, but I'm happy to share some of the tools that we created for recovery coaching. And then we have a toolkit and a train the trainer that Voices of Hope that we created with a Kentucky DPH grant that we're happy to share with the state. And then our marketing materials and our educational inserts, and we have them in Spanish and English. And then if you're interested in adding the empowerment measure to your tools, please reach out to me if there's anything that you want to work with on this. And I can also connect you to Dr. Fallin-Bennett. I'm sorry I didn't put your info there.